Okay, so as Kathy had stated, my name's Kayla and I worked with Danielle and Molly, and our research was titled Occupational Therapy Life Hacks Group for Individuals with Chronic Stroke, and it was a pilot trial.
So our research question was, can an IADL-based group improve performance in self-identified problematic tasks in individuals with chronic stroke? And IADL stands for Instrumentals Activities of Daily Living. So the purpose of this study was to implement a pilot trial to establish an occupational therapy group for individuals with chronic stroke that would focus on improving occupational performance. And this would be done through collaborative problem solving and discussing shared experiences amongst participants. And also the purpose of this group focused mainly on difficulties participants have while they're engaging in IADLs. So the research design that we used was a single subject case study with a mixed methods design in order to collect both qualitative and quantitative data. This study included one participant, and to be eligible for this study, participants had to meet the following inclusion criteria. They had to be a community dwelling adult, be a minimum of 3 months post-stroke, and be older than 18 years old. To collect the quantitative data, a customized version of the Instrumental Activities of Daily Living scale called the MIADL scale with considerations from the Canadian Occupational Performance Measure called the COPM was used. And this scale was administered pre and post group. To collect the qualitative data, a post-group survey was used with 4 open-ended questions. The intervention that was implemented was 4 60-minute groups. Each were focused on a different IADL activity, and these groups were held weekly for 4 weeks. Once all the data was collected, data from the MIADL scale, pre and post test, was comparatively analyzed. A traditional qualitative analysis was done to analyze the post-group survey.
So now moving on. Questionnaire that Molly mentioned, and this table includes ratings from both before and after the activity session. So overall, the ratings for each task showed improvements, especially in her performance and satisfaction with the task. However, as you can see, her importance level for various tasks went down, but we felt this was due to her interpretation of the question, which may have been, how important is it for you to learn how to do this task? And since she had already learned new techniques, it was no longer a great precedent for her to learn how to do it. Additionally, we wanted to discuss her ratings for medication management. So as you can see, her ratings for satisfaction declined immensely. And we believe this was due to her inability to practice the techniques that she learned from the session at home, which was done after the 3 previous sessions. So this task area was conducted in the final group. Therefore, there was no opportunity for her to practice the newly learned skills and determine whether her performance improved in her home environment before this questionnaire was administered. And then next, we want to share some quotes from our qualitative portion of our study, which was the post-group survey we administered. So this survey asked the participants to share, our participant to share their opinion on how the groups were run, the effectiveness of the group, and any ideas for improving future group sessions. And from her responses, we felt these quotes encompass her overall feelings and opinions towards the group. So the first quote says, cleaning surfaces, food prep, folding laundry, it's given me the confidence to do all of them. So after engaging in groups focused on these areas and practicing various techniques, it gave her the confidence and motivation to begin performing these tasks at home. She then stated, carry over immediately to the house. That was practical. Each session included equipment and techniques readily available to use in the home. Therefore, it was easily transferable for her to begin practicing and utilizing within her own home. And then lastly, she said, found it empowering to figure out techniques on my own. So the participant found the approach that we used during the groups to be empowering, and it allowed her the opportunities to try out and practice techniques that would be most useful to her. And Kayla's going to go more into information about our approach in the next slide.
So to go a little further into our discussion, one important point that we took away from our research is that the group gave the participant confidence in her ability to do task practice in the sessions. So as Danielle said, this group was able to alter the habits that the participant and her husband had created over the many years post her stroke. And we noticed, and it was kind of interesting to see how eager she was and how proud she was to share what she learned with her husband once he came and picked her up. She was also able, again, to translate the skills learned in the group. And then as facilitators, we gave the participants strategies to perform each task. And like Danielle said, we encouraged the participant to try things her way and with her strategies. And this really helped with the carryover, which goes into our theory that we use, which was co-op. And a big part of co-op is like a plan, do, check approach. And the participant was able to identify the goal within the session. So for example, our sessions were centered around laundry, medication management, household tasks, and food prep. So with the laundry, for example, she kind of didn't like our approach and the topics that we taught, and she learned her own way. And then with her own way, she went home, practiced that, and came back and kind of discussed how it helped her at home and in different ways that we can adjust the strategies that she implemented and to make it easier for her to kind of make more goals for herself at home. So that kind of went along with the co-op approach, which proved that this approach does indeed help these type of IADL groups. And then to conclude, we talked a little bit about clinical implications. So to start, we kind of related this group to the summer stroke group, which is more activity-based group with games and different arts and crafts. So with the results that we got from our group, we believe that the summer stroke group, which is usually held during the summer semester, the first semester for PY2s, we believe that more IADL tasks should be implemented. And this is especially important because our one participant does attend the summer stroke group, and she herself brought up how beneficial it might be to include IADL tests in the summer group. Additionally, but we believe that IADL tests should be emphasized in treatment during initial occupational therapy services. Traditionally, it's more of like an ADLs that are taught in initial therapy and functional ambulation, for example. But as we saw, stroke survivors don't typically perform IADL tests by themselves, and they rely on greatly on a caregiver. So we believe that IADL tests should be implemented during the early phases of OT treatment. And then since this was a pilot trial with just one participant that we received the results and data from, further research should be conducted on the effectiveness of this IADL-based stroke group with a longer time frame than 4 weeks.
So Kathy introduced us, but as I said, I'm Melissa, and then we had Andrew, Katie, and Ren in our group. And so our group was wanting to look into the different assistive technologies that helps clients with cognitive deficits. And so after doing our research and our lit review and everything, we came up with our title of Assistive Technology in Clients with Acquired Brain Injuries, an exploratory study on the use of AT by these occupational therapists.
All right, so before we get into the different aspects of our research, we just wanted to give you guys a little bit of an overview of what an acquired brain injury is. So generally speaking, an acquired brain injury, or ABI, is an injury to the brain that occurs after birth and results in some sort of alteration of neuronal activity in the brain. These changes have the potential to leave individuals with a wide variety of long-term impairments that may alter their performance in everyday activities. So an ABI can be categorized into two types. Traumatic brain injuries are caused by external factors or some sort of traumatic impact. ABIs can also be non-traumatic. These are caused more by your internal factors, such as a stroke or a lack of oxygen to the brain. And then assistive technology, what's that? It's also known as AT. It's really any form of device or system that allows a person to perform certain daily tasks they would otherwise be unable to do on their own with success or with safety. So AT can include things like smartwatches, smartphones, different apps on your phone, but it's really not limited to that. And we'll get into that a little bit later on.
So with this valuable background information that we gathered on both acquired brain injuries and assistive technologies, from here we were able to develop our research questions for the entire course of the study. First and foremost, we wanted to find out what types of assistive technologies occupational therapists use in practice to help individuals with acquired brain injury compensate for cognitive deficits. And second, we wanted to find out how occupational therapists go about selecting and implementing ATs for clients with ABI. And with these two research questions, we were able to develop our objectives, which we also used to help guide our research study. These objectives included investigating what types of assistive technologies OTs are implementing with clients with ABI in practice today, discovering what cognitive deficits are addressed with AT, discovering also what barriers may possibly affect the use of AT, and last but not least, exploring how OTs implement and train clients and their caregivers in the use of AT during treatments.
So we wanted to go over how we obtained our participants in our study. So we called a variety of rehabs, hospitals, inpatient, outpatient facilities across the United States who work with clients with ABI. So we spoke to individuals in the OT department, getting their email address and looking if they're interested in our study, where we were able to send them our survey. So we posted on different Facebook groups. We are actually able to join the Springfield College OT alumni group a few months early. We were able to post in there, and other Facebook groups where we posted info about our survey and our link. We also posted in the AOTA Community board as well as LinkedIn. So our survey is anonymous. We don't know exactly which people from what facility filled out our survey, but we had some demographic questions that we were able to get an idea of what setting they worked at. Our inclusion criteria is just any registered OT license working with clients with AT in the past year. And we excluded CODAs and clients that work just with dementia and who do not speak English.
And so a little bit about our design. We made a 17-question survey on Google Forms, and it was including multiple choice questions and then also check all the apply boxes. And then we also had a couple of open-ended short response questions. And then we left the survey open for about a month on those platforms. And then after that, we used Google Forms and Excel spreadsheets to gather frequencies and percentages and then some themes within our short answer responses and our data.
So as a result of implementing these research methods, there were a total of 7 occupational therapists who participated in our study, all of which reported implementing some form of assistive technology in their treatments. Each of the OTs reported having experience working in a variety of settings. These settings included outpatient clinics, community-based rehab, home care, vocational rehab, and also both subacute and inpatient rehab. Regarding the OT's experience working with acquired brain injuries, 2 OTs reported having at least 1 to 5 years of practice experience. One of the OTs reporting having around 6 to 10 years of practice experience. And last, a total of 4 OTs, being more than half of our sample, reported having more than 10 years of practice experience. Of the 7 total participants, 3 of them reported having some form of specialty certification. One OT reported having a CBIS certification, which stands for a Certified Brain Injury Specialist. And then the two other OTs reported having what's called a ATP certification, which stands for being what's called an Assistive Technology Professional.
Then some of the deficits that occupational therapists reported in treatments of working with their clients with ABI, all 7 of them reported poor concentration and focusing, poor planning skills, short-term memory impairments, poor organizational skills, difficulties with time management, and then 86% of our OTs reported poor sequencing skills and difficulties with problem solving. And then other reported was long-term memory impairments and limited insight, but less reported.
So we asked the OTs, what kinds of AT are you implementing in today's practice? So all 7 said they use smartphones, computers, laptops, and iPads. These are things that you guys are on right now to access Zoom. You know how helpful they can be with different apps and how to remember how to do something. Almost all said they use electronic calendars, reminders, planning apps, watches, timers, alarms to help you get up in the morning when food's in the oven or laundry's in, to help you remind you when those things are done. Planners, calendar, wall charts, sticky notes. These are helpful just to jot some things down for some short-term memory. Other softwares, and then about half of the OTs said they use prompting devices, Siri voice commands, and fewer said they use personal digital assistant cameras, which can be helpful to take a picture, go to the supermarket, whatever you need, and be able to look back at that picture of what you needed. Smart pens, live script pens, location tracking devices, and dictaphones were fewer. So we wanted to talk about some of the common barriers that the OTs said that they find when implementing these assistive technologies. So as you know, with ABIs, they had those cognitive deficits, so they may forget to even use the AT that they prescribe. They also talked about insurance being high, which can be expensive, some of these technologies, and then client inexperience. They may not have been familiar with this AT before their injury. Other OTs said that fewer OTs said that limited time, fear of using the AT, and malfunctions with the technology and caregiver inexperience are also barriers that inhibit the use and to be mindful of when implementing these in your practice.
So when implementing AT, the therapist really emphasized the importance of using an individualized client-centered approach. This would include interviewing the client, engaging in discussions, and making clinical observations. The therapist also reported using the human activity assistive technology model, as well as the student environments, tasks, and tools framework as theoretical models guiding the implementation of AT. All of the therapists actually reported the importance of individualized hands-on therapy. 4 specifically reported that they frequently assess carryover of skills into environments outside of where therapy typically takes place. It's interesting, in an open-ended response to a question addressing AT's effects on caregivers, 2 therapists actually reported that the process of learning how to use AT may initially be a burden for caregivers. However, all 7 therapists reported that AT has the potential to eventually decrease this burden of care as clients become more independent with their everyday tasks. So with our research, we see a lot of clinical implications in the field of OT. As stated before, there are a variety of ATs used in practice, but with technology always expanding, it's really important for OTs to stay up to date with emerging technologies, as well as evidence-based research that supports the effectiveness of AT in practice.
And with technology expanding and there being a variety of ATs currently used in practice today, it is essential that OTs take an active role in the prescription of AT for clients with ABI in order to aid in alleviating any such cognitive deficits and or barriers many of these individuals face to enable them to become more independent, therefore potentially decreasing the further need for caregiver support.
And then, as always, as OTs, it's important to be client-centered. And through doing this, through interviewing and implementing specialized assessments, as Andrew said, the hat and the set. And then previous research also mentioned the OT-IPM, which is the Occupational Therapy Intervention Process Model. These help us match the client with the most appropriate AT and the most effective way to maximize their function and their independence. And then just a little bit of insight, the HAT model, it's based on human performance and recognizes that AT can enable and enhance person's abilities and includes their social and cultural aspects as well as their environmental and physical conditions. And then the SET model is a 4-part model that promotes collaborative decision making and evaluates the effectiveness of the AT. So with our research, we didn't know these models beforehand, but we found them in our research.
Many of the OTs discussed that they use a trial and error approach. So it's the first time that you implement an AT, it might not be the right one, and that's okay. So you want to give the client opportunity to try different ATs to see which one works best for them, which one's easiest for them and their caregiver. So this way they're more comfortable using it and it matches their needs and deficits best. This way you can ensure carryover in the clinic, in their home, when they're at work or school, as well in the community. So it's okay if like you're not sure the first time which AT is best, but just do a trial and error approach and you'll be able to find the right one for them.
Okay, how is everyone doing? I hope you're having a great day today. My name's Emily, and my partners are Nicole and Brianne. And our topic is the comparison of perceptions of occupational therapy in Morocco and in the United States. So our research question was, what are the perceptions of occupational therapy through the eyes of the first graduating cohort of occupational therapy students in Morocco and occupational therapy graduate students in New England? And so why we chose this question was we all sat down and discussed that we had an interest in working abroad, and we also all lived abroad. So we were kind of curious about how different OT is among students around the world. And so some of our objectives for today are we're going to explore the perceptions of OT through the eyes of OT students in Morocco and OT students in the United States. OT was introduced to the country of Morocco in 2015 after much evidence was found demonstrating how OT could benefit the population. Since the creation of OT educational program in Morocco almost 4 years ago, the first graduating cohort of Moroccan students are preparing to go out in the community and to treat patients. Due to the start of a new program, many questions exist regarding the training obtained by OT students in Morocco in comparison to the training obtained by OT students in the United States. Differences in culture, healthcare practices, rural and urban gaps, and perceptions of disability call into question the differences in healthcare practices among Morocco and the United States.
So we used a self-reported survey through Google Forms that had a mixed methods design. So it was broken down into 3 sections. The first section was designed to collect demographic data. The second section was designed with 3 questions on a Likert scale, and the third section was qualitative short answer questions. So we had 3 cohorts of students participate. We had 2 from the US and 1 from Morocco. The US students were in their 2nd professional year, and the OT students in Morocco were in their 4th year. So we recruited participants via email. We had faculty members from each program send the link to the survey along with a brief explanation for students. We held Zoom sessions for students in programs B and C to answer any questions that they might have. And then we administered, like I said before, the survey through Google Forms. So we opened it around mid-March, and we gave students about a month to complete it if they chose to do so. So it stayed open until mid-April. And then we used a statistical analysis and qualitative thematic analysis to compare the responses. So our first section was demographic information. So the table to the right gives you guys an idea of the demographics among all 3 cohorts. And then we also pulled out information for each cohort to compare the demographics. But just as a general, we had 29 students from program A in the US, 20 students from program B, and 3 students from program C, which was the program in Morocco. We had combined program demographics, as I said, picture to the right, but 51% were 18 to 24, 87% identified as female, 79% were white, and 87% said English was their native language. So for our Likert scale questions, we had 3 questions on a scale of agreement. So the first question asked, I feel comfortable working with people with disabilities and chronic illnesses, and we found that the majority responses, or 50% of the responses, were in the strongly agree category. The second question said, I believe individuals with disabilities and chronic illnesses deserve to be treated fairly and equally. So we had 92% in the strongly agree category. And then the third question said, I feel thus far my education has prepared me well for fieldwork experiences. And we had 65% in the agree category.
And then for part C of the survey, which included the 4 short answer questions, the first question stated, how and where did you first hear about occupational therapy? A common theme that arose from the students in programs A and B was having a personal connection to an occupational therapist or having a family member receive occupational therapy services. A common theme among all 3 groups was the discovery of OT through a personal job search online. And regardless of how OT was discovered, another common theme was the immediate draw to the career. Question 2 asked, what influenced you to study occupational therapy? Common words that emerged in the responses from programs A and B included client-centered and holistic practice. Another common theme among all 3 programs was the ability to work in a field that would help others. Question 3 asked, what do you hope to accomplish as an occupational therapist in your country? Programs A and B common themes included improving quality of life for clients, advocacy and education. Program C talked a lot about people with disabilities, equal rights, and providing services for individuals with disabilities. In question 4, in your own words, how would you define occupational therapy? Common themes and words among all 3 programs included helping people and regaining skills and independence. In programs A and B, common themes included client-centered, whole person, and adaptive techniques and equipment. Clinical applications based on our research are when working with clients from different backgrounds to remain aware of cultural differences. For occupational therapists who may end up working internationally is to remain aware of the difference in occupations around the world and their different healthcare systems. When sending your survey abroad, plan to translate that survey into their native language to include better results. And individuals with disabilities deserve equal and fair treatment, and that was found between all 3 programs. And suggested further research includes follow-up survey with the cohorts in Morocco and the United States. Could also be used to gather more information from students once they've completed their required clinical experiences. And the same survey can be completed by cohorts of occupational therapy students in other parts of the world. Overall, gathering different perspectives on occupational therapy around the world will help current and future occupational therapists to work more effectively in their increasingly diverse communities at home and abroad.
And that concludes our presentation. As Kathy said, my name's Grace, and I worked with Juliana, Devin, and Rachel, and we conducted a research study exploring teachers' perceived benefits and barriers of outdoor play in children from kindergarten to 2nd grade.
So our initial research questions that I feel like we created like years ago, but maybe just months, were what are teachers' perceived benefits and barriers of outdoor play for children kindergarten through 2nd grade? How does outdoor play improve or detract from participation throughout the school day? And how does outdoor play contribute to learning and the physical, emotional, and social development of children? Additionally, our objectives for this project was to explore teachers' perceptions of how outdoor play improves or detracts from a child's academic, social, physical, and emotional participation throughout the school day, and to discover existing barriers that prevent children from participating in outdoor play during the school day. So we were really curious about how recess and outdoor play like will impact an student's ability to be successful throughout the school day. So that's what we were really curious about physical activity and how that contributes to academic performance.
So we used a mixed methods research design via an anonymous electronic survey using Qualtrics. Our participants were 20 K through 2 teachers in the United States. We recruited these teachers using convenience of snowball sampling through both social media posts and emails and texts.
And then these participants were encouraged to send the survey to other people they may know who fit the inclusion criteria. The actual survey took about 15 to 20 minutes to complete, was available for 5 weeks, and it consisted of both quantitative and qualitative questions. The quantitative questions were analyzed via Qualtrics, and the qualitative questions were analyzed by the researchers through a thematic analysis.
So our participant demographics, we had a total of 20 participants. Only one was male and 19 were females. Participants' age ranged from 22 to 59 years, and experience ranged from 1 to 35 years. There were 7 kindergarten teachers, 5 first grade teachers, and 7 second grade teachers.
So as Grace said earlier, due to the nature of our survey, we collected both quantitative and qualitative data. Some of the most striking quantitative data that we found included the length of outdoor play throughout the day, how often students were kept inside from outdoor play, and how many students were affected by teachers keeping students in from outdoor recess. So you can see the table on the top right that represents how long the outdoor play was for each class. And you can see that the most frequent outdoor play time was 20 minutes. And then the second most frequent time was 30 minutes. So through our research, we found that it's actually recommended for children to receive at least 60 minutes of physical activity per day outside. And then previous research also indicated that students should be receiving 10 to 15-minute breaks of outdoor play for every 40 to 15 minutes of sedentary classroom activities. So we were really drawn to that because is 20 minutes really enough for these students then? And then going beyond that, are parents able to achieve the additional 40 minutes of unstructured physical activity to reach that 60 minutes? And then the next thing that we saw was how often students stay inside from outdoor play. And 65% of teachers reported that students were denied outdoor play 0 times per week. 30% reported this occurs 1 to 2 times per week. And only 1 teacher indicated that this occurs 3 to 4 times per week. And then in contrast, 100% of the teachers reported that between 0 and 24% of their students miss opportunities to go outside at least once per week due to misbehavior, academic performance. So it kind of demonstrates that it's the same kids who are being kept inside from recess. And then for our qualitative data, we found the following themes that were observed throughout the participants' responses: that outdoor play improves attention of students, it aids in the development of social skills, and through the open-ended questions, we also found that teachers reported certain barriers that prevent outdoor play. So looking at the table on the bottom right, we can see that primary barriers, just meaning they occurred more frequently, included the weather, curriculum demands, students' performance in the classroom, and time available throughout the day. And then secondary barriers included inability or difficulty with bringing instructional materials outside, limited staffing, students' attire, the students' ability to socialize with peers. One person even recorded COVID-19 as a barrier. I think more people would record that as a barrier right now. And then one teacher reported that there were no barriers. So then on this slide, we just included some quotes from teachers that we found were important. A lot of teachers talked about the importance of students being able to socialize and to interact with people outside of their immediate class. This provided them with ability to socialize with other peers, but also just to get a break from some of the people in their class. And they talked about how as adults, we need that too. It's tough to be in the same room with the same people all day. So just having that break and being able to socialize with people in other classes. They talked about how outdoor play promotes good communication and the language skills that kids need. And then it also assists with coping skills, problem solving skills, and negotiation skills. And then outdoor play helps them to be more engaged in the classroom. And then one person who reported no barriers to outdoor play emphasized and just said that at their school, recess is rarely used as a punishment. So most children do have the opportunity every day to engage in outdoor play. And it was interesting to see that they said this was a conscious decision made by the staff as they understand the benefits and the value of outdoor play for children.
So just going over some clinical implications. So as you can see from our results and conclusions, outdoor play is very beneficial for school-age children to help improve their attention and develop social skills. So occupational therapists who are working in schools can become advocates for outdoor play and assist with promoting many different areas of outdoor play. So we came up with some specifics. So OTs can shed light on the importance of making sure that children are spending enough time outside during the school day. Like Rachel was saying, from our research, we found that children should be receiving 60 minutes of physical activity a day. OTs can also help teachers and administrators come up with alternative consequences for children besides taking away outdoor recess or play, since outdoor recess is so valuable to children and many times they aren't getting enough time outside. So taking that away is something that really should not be done. And lastly, OTs can provide ideas for indoor recess that continue to work on improving attention, creativity, socialization skills, and encourage independent problem solving. So therefore, similar benefits can be seen following indoor recess that outdoor recess could have provided. And we all know living in New England, the weather is unpredictable, so it's really important to have some indoor activities that really highlight those areas as well.
Hi, everyone. So our topic was understanding teachers and trauma-informed care. And my name is Jacqueline Davis.
David Texera.
Laura Keelik.
And Rachel Fellio.
And our advisor was Andrea Capola, and we just wanted to thank her for all of her support throughout this year.
Oh, sorry.
So we studied the comfort, knowledge, and competency of elementary school teachers. And here are our questions. Our first question was, what are elementary teachers' comfort levels in working with children who have experienced trauma? What are elementary teachers' level of knowledge surrounding trauma-informed care? How competent do teachers feel in meeting the needs of the student population to promote successful function and engagement within the classroom setting? And according to teachers' perceptions, how does trauma affect students' abilities in the classroom? So these are the questions that we based our research off of, and therefore the purpose of this study was to investigate the answers to those questions. Then we also wanted to provide a brief overview of what trauma-informed care is, and this is based on a couple of the articles that we've read. Specifically, this one's based on Corello and Butler, but basically staff and other service providers routinely screen for trauma exposure and symptoms, and these symptoms vary. We'll get into that as the presentation goes on, but mostly these symptoms relate to irritability, concentration difficulties, dysregulation. So a lot of times kids who have experienced trauma may have trouble calming themselves down and developing coping strategies for themselves. Then aggression and just overall anxiety and fear are also other symptoms that are often associated with trauma. An important aspect of trauma-informed care is to link these screens and this information and to use this info to accommodate to their needs. And 5 principles for establishing trauma-informed care. So these are basically like 5 different ways that teachers can meet the needs of these students is by ensuring safety. So just promoting a safe environment within their classroom and just creating trustworthiness. So that goes along with ensuring safety. Maximizing their choice. So giving them the autonomy of choosing what different activities they would like to do and how they would like to learn. And then maximizing collaboration and prioritizing empowerment. So really building them up.
So our study was a mixed methods design. Our group used an electronic survey, which included both descriptive and narrative data. We used convenience and snowball sampling methods in order to gather data. The survey was open to teachers for a total of 6 weeks. The platform used to create the survey was Qualtrics, and the survey included 15 questions. The questions varied and included Likert scale-based questions, closed-ended questions, and open-ended questions. So a total of 31 teachers from grades 1 through 5 filled out the electronic survey. There were an even spread of teachers throughout all grade levels. Of the teachers surveyed, the average teaching years of teaching experience was 15.23 years. A majority of the teachers reported having at least 20 students in their classroom. Of those students, the average number of students who were formally identified as having experienced past trauma was 4.35 students. So our study looked at familiarity levels of trauma-informed care and how much training teachers had had on the subject. A small percentage of teachers stated they were familiar with trauma-informed care, and over 90% of the teachers stated they did not receive enough training in the area. They thought that they would benefit from more training. Majority of the teachers did not feel comfortable in identifying traumatic stress symptoms either. The majority also did not feel knowledgeable or competent in meeting the needs of the students who had past experiences of trauma.
So for our qualitative results, we looked at all of the teachers' responses to the open-ended questions, and we identified 4 common themes among their answers. And the first theme we came up with was the negative impact of behavioral issues. So some of the negative behaviors described by teachers include verbal and physical aggression, disruptive behavior during class instruction, explosive behavior, impulsive behavior such as leaving the classroom, and withdrawal of the students, which the teachers described as shutdowns. Many of the teachers identified the negative behaviors as having a negative impact on the students' schoolwork, contributed to difficulty paying attention and focusing in class, and was also disruptive to their peers in the classroom. The second theme we discovered was difficulty knowing how to assist students with trauma. So the teachers indicated that there is a general lack of resources provided by schools, and they are oftentimes unaware of the backgrounds and experiences of their students, and that makes it really difficult for them to understand their needs and how best to help them. And teachers also, as Dave said, indicated that they have not received enough training in trauma-informed care, which contributes to why they do not know how to respond to students, especially when they are acting in a way that disrupts the learning environment. The third theme we identified was the strategies of teachers working with students. So many teachers use behavioral approaches in the classroom, such as behavioral charts, setting goals with rewards, positive praise, and they use all of these as forms of motivation. And many teachers also utilize sensory approaches, such as allowing students to wear headphones when classroom noise becomes overwhelming for them, or taking a walk for some extra space when they need it. They also use overall classroom adjustments, such as visual schedules and directions, giving extra time to complete assignments, and being flexible with seating arrangements, which have all led to more positive behaviors as well. And in regards to how they treat students who have experienced trauma, many of the teachers disclose that they tend to treat students who have experienced trauma a little differently. They tend to be more cautious when disciplining, are more patient and sensitive to situations, and give more attention to students who have experienced trauma so that they can make accommodations and modifications in the moment when it's necessary. And one really important thing that the teachers all identified was that building relationships is essential in order to gain the trust of a student, in order for them to feel comfortable opening up and for them to feel safe in the classroom. And one quote that a teacher said in regards to this was, "When working with a student who has experienced trauma in the classroom, I believe that I facilitate success with them by building a strong relationship with them. I think when a strong foundational relationship is built, a student begins to trust you more and be more open to working with you academically." So this just goes along with why teachers find building relationships is important. And then our last theme we came up with was the role of occupational therapists in working with students who have experienced trauma. So teachers reported their level of agreement regarding OT being beneficial for students' function in the classroom for students who have experienced trauma. And 37.5% of teachers reported neutral, 50% reported they agree, and 12.5% reported that they strongly agree. And all surveyed teachers indicated that a very minimal amount of their students receive OT services as part of their trauma-informed care plan. Many teachers indicated that they are not aware of the role that OTs have in assisting students who have experienced trauma, but there were a few that described their knowledge of OTs, and that included utilizing sensory strategies such as facilitating activities in sensory gyms. And teachers were also aware of the use of coping strategies in order to help students feel safe. And another quote that we pulled from one teacher's response said, "I believe that the occupational therapist's role is especially crucial during the beginning of a trauma event to work with other specialists as a team to give students as much support as needed, depending on the trauma. I have seen occupational therapists use sensory strategies and academic support with writing. Also, occupational therapists may help with emotional, sensory, and overall development issues with students who experience trauma." And that was obviously from a teacher who just was more aware of the role of OT.
So for our clinical implications, overall, the results of the study show that there is a need for elementary school teachers to participate in additional trauma-informed care training so they can become knowledgeable on how to best meet the needs of their students who have experienced trauma in the school environment. The results indicated that there is a general uncertainty on how teachers can assist their students who have experienced trauma, and this finding is consistent with previous literature that we read as well. And we also found that the training teachers have received pertaining to trauma-informed care has not provided them with the skills and knowledge to better understand and assist their students. The teachers also have not been educated or trained on how to promote carryover of trauma-informed care practices into their classrooms as well in order to adequately support their students. So we concluded that future training for teachers should further emphasize strategies and interventions that can be utilized to facilitate learning and regulate classroom behaviors. The training should also include education on recognizing signs and symptoms of trauma. As previous literature informed us that it's important for teachers to have knowledge of these signs and symptoms so they can then determine effective interventions or accommodations that can be provided during any negative instances. So school-based occupational therapists, as members of a multidisciplinary team within the school environment, should be encouraged to promote awareness of their unique role in approaching trauma-informed care practices using a holistic approach. They can also discuss the available options for students, as well as assist with implementation of various strategies to improve students' social and academic function within the classroom. And that is it. Are there any questions?
Thank you. I am seeing some questions showing up. The first question is, were you able to share any resources with those teachers who reported not having enough training in trauma-informed care?
We actually weren't. We had to keep the survey anonymous, so we actually don't even know of the teachers who filled out the survey.
Next question, what types of trauma assessments are available?
I do not know any specific assessments.
That wasn't one of the things that we really looked at when coming up with our survey. We more just wanted to know the teachers' familiarity and knowledge about it, but I think that's definitely something that we could look into for the future.
Were you able to determine if trauma-informed care is successful in decreasing symptoms, either through your study or did you find that in the literature?
Looking at previous literature, we were able to kind of find that trauma-informed care was successful in decreasing traumatic symptoms in students who had experienced past trauma.
The behavioral and sensory approaches in the classroom, the teachers really found helpful in regulating their behaviors and allowing them to be more successful in the classroom.
And just to add, a lot of times a longer term approach for trauma-informed care is more beneficial. So as we mentioned in the presentation, it's like really important that trauma-informed care begins as close to the trauma as possible. And that way the effects can like be more longer lasting.
All right, and then kind of the flip side of this is the next question. Do you think it would be beneficial for OTs to have more knowledge of educational methods teachers use so that when they're offering trauma-informed care suggestions, it would ensure greater compatibility with the teacher's instruction strategies?
I think a lot of
I think that goes along with like professional collaboration too. Like I think it's really important that as much as we recommend these techniques for teachers, they obviously need to be techniques that fit their needs, and like each classroom setup and each classroom environment is different. So as much as we as occupational therapists can understand their specific situation and the specific students they're working with, as well as their overall classroom environment, I think the better we'll be able to meet their needs.
David, did you want to add to that?
I was just going to say, from previous literature and from our own study, I think we both saw that a lot of the teacher struggles were kind of working with that particular student who had experienced trauma, as well as the rest of the students in their class. So kind of, as Jackie said, bringing in an OT to analyze like client-to-client situation of different classrooms, because every classroom is different, and how they can like help implement these strategies and working with that specific child that may be struggling, but also working with the other 19 to 20, 25 kids in their class.
Yeah, and then one more follow-up question. It seems like OTs often aren't advocating for all the many things we can help with in schools. Any suggestions for how to make OTs more aware of all the different ways we can help?
I think this goes a lot along with like just having like not even trauma-informed care session, but just like staff-wide meetings. And I know they do have that, but even like splitting up into small groups and just making sure that all the needs are addressed by not only the OTs, but also the other service providers in the school. And I think teachers and staff members who are with kids most often can like have check-ins and express the needs of their classroom with each of the service providers. So that'll make sure everything's on the same page and everyone's needs are being met.
Mm-hmm.
I agree with that. Just having that positive relationships with the teachers and open communication. OTs can figure out whether it's related to trauma or not, what those teachers need assistance with in the classrooms, and then can figure out how best they can be of service to them and vice versa.
Okay, so the title of our study is The Experiences and Coping Strategies of Caregivers of People with Dementia Who Attend a Memory Cafe. I'm Shelby, and then I also worked with Jill, Jessica, and Haley. So to tell you a little bit about what the Memory Cafe is, it is a support group for caregivers and their loved ones who have dementia. The specific Memory Cafe we attended was at the Hamden Senior Center, where they host this support group every Friday, and they provide various activities for the caregivers and their loved ones to participate, from crafting activities to musical activities and physical exercise classes. So for our research, we attended 3 of these sessions. So our main research question is, what are the coping strategies used by family caregivers of people with dementia who attend a memory cafe? The purpose of this study was to explore the caregiving experience of caregivers of people with dementia who attend a memory cafe, with a specific focus on the types of coping strategies that they use. So our main objectives were to identify coping strategies used by caregivers and their perceived effectiveness, as well as explore the caregiving experience and the experience the caregivers had at the memory cafe.
So for our methods, we had a mixed methods approach, and our inclusion criteria included a family caregiver for a person with dementia, and they attended at least one meeting at the Memory Cafe. And for our exclusion criteria, it was caregivers who were paid to provide care for the person with dementia, or they were not a family member.
So our first outcome measure is the Carer's Assessment of Managing Index, or as we call the CAMI. It is a 14-statement questionnaire with a Likert scale from 1 to 4, 1 being I don't use this, to 4 being very helpful. So this you'll see on the next slide, actually. The statements consisted of various coping strategies, and the participants went through and marked off what strategies they found to be most and least helpful.
And then we also created a demographic questionnaire. And this was really just to get the participants' age, their gender, their relationship to the person they cared for, and how long they've been attending the Memory Cafe.
So participants also had the opportunity to participate in a semi-structured interview that focused on identifying their coping strategies, their experiences providing care, and their Memory Cafe experience. These interviews were held during the Memory Cafe meeting times, and they could participate in individual interviews or a focus group. Questions were asked such as, how has your life changed now that you are caring for your loved one with dementia? How would you describe the Memory Cafe to someone who has never been before? And when faced with a challenge related to caregiving, describe how you address it.
And then during our time at the Memory Cafe, we participated in the weekly activities. And while we were participating in the weekly activities, we observed the interactions and relationships between the caregivers and their loved ones, as well as between the group leaders and the caregivers. And this was all documented through field notes.
For data analysis of the CAMI and demographics, we used descriptive statistics for socioeconomic characteristics of the caregivers. Then the CAMI scores were put into percentages by the amount of participants that scored 1, 2, 3, or 4 for each statement.
And the interviews were analyzed by using an open coding system and a constant comparative method to identify themes, so that each interview was transcribed verbatim and the researchers read through them, comparing one interview to the next when searching for commonalities between them.
So for our participants, these graphs were created with the information that we received from the demographic questionnaire. So 9 caregivers participated in our study, and that included 8 females and 1 male. Caregivers' ages ranged from 46 to 85. And as you can see, there's 2 different age groups, and this is just to showcase the age range and kind of which range the caregivers and the recipients fell more into, just to give you an idea. Most caregivers were wives, however, 1 was a father, 1 was a mother, and a couple of the caregivers were daughters. Recipients included 5 males and 2 females, and their ages ranged from 49 to 87. And of the 9 caregivers, 6 were currently living with the recipient. And caregivers, they also attended the Memory Cafe from 3 months to 3.5 years, which is actually when this Memory Cafe first began. Recipients had been diagnosed with dementia from 2 years to about 6 years ago. However, on the other hand, caregivers have been caregiving for about 5 months up to 10 years.
Okay, so in the top left corner, we have a little piece of the CAMI survey percentage results. We chose the statements where 75% or more of the participants scored a 4 or found the statement or coping strategy to be very helpful. The top strategies found were finding information, identifying problems and creating solutions, as well as seeking and having professional help.
So from our interviews, we came up with 5 conceptual themes. Our first theme is titled Just Deal With It. So Just Deal With It was taken directly from an interview with a caregiver, and it pertains to how the caregiver handles the day-to-day struggles and challenges that arise when caring for a loved one with dementia. And we found 2 ways in which they do this. The first way being appeasement, and this is just basically that the caregiver does whatever it takes, whether it's a little white lie or some sort of distraction to keep their loved one content and appeased. And then they also express the use of resources around them, such as family members, other caregivers, support groups like the Memory Cafe.
So our second theme is the shift in focus and priority areas. Many caregivers spoke about, since the diagnosis with their loved one, how they had to shift their focus to focus pretty much solely on their loved one with dementia, which often involved foregoing many activities that they had previously participated in. One participant said, "Our life has become a complete turnaround basically because everything now revolves around her, the person with dementia. You know who she is, what she's capable of doing, and what she wants to do. I decided that her last day of work was also my last day of work." So people really had to shift their lifestyle in order to provide care. The next theme is the sense of family, and this is referring to the Memory Cafe as a group. This was also seen as we observed the meetings where members greet each other with hugs and by name and are happy to see each other every week. Participants described the group as warm, welcoming, and accepting. So within this theme of sense of family, there are two categories, the first being acceptance. Many of the members there felt that both them and their loved one with dementia were accepted for who they were and what they were capable of doing. They felt comfortable in the group and they didn't feel as though they were being judged. Another thing that added to this theme of sense of family is that participants felt they were able to bond with one another over the shared experience of caring for a loved one with dementia. They felt that members in the group understood them, and they said, "Everyone is going with the same issues that you have. So you feel accepted, you feel understood," and they felt a strong sense of commonality with the other caregivers.
And then our fourth theme is titled Sense of Relief. Many of the caregivers expressed that when they attended the Memory Cafe, they felt a sense of relief because they were able to enjoy an activity with their loved one in a comfortable setting.
And the last theme is the theme of connection. And this theme focuses on the social connection that caregivers and participants and their care recipients were able to get from coming to the Memory Cafe. So they bonded with people there. There were friendships formed. There was a strong sense of social support. And on the other hand, they also were able to connect with the group leaders to gain valuable information and resources about how to better care for their loved one. So there were two senses of connection, both connecting with others socially and also connecting to gain more information.
So for clinical implications, occupational therapy implications, occupational therapists have a unique skill set and training that can allow them to further progress and develop memory cafes such as this one. And when treating a client with dementia, it is imperative to include the caregiver within the treatment sessions and making sure that they are aware and have access to resources in the community, such as this memory cafe and other support groups.
For future research implications, we think it would be beneficial to conduct this study at other memory cafes in order to generalize the results. We also think it'd be beneficial to provide further research regarding whether or not the caregivers receive formal education from professionals, such as OTs.
And we would really like to thank the Hamden Senior Center Memory Cafe participants and group leaders for participating, and of course, our research advisor, Dr. Joan Simmons, for all of her support.
Okay, so our research today was the relationship between animal-assisted therapy and symptoms of PTSD. So our objective was to understand the relationship between animal-assisted therapy, which we will refer to as AAT, and post-traumatic stress disorder, which is PTSD, which we'll discuss later. So our research questions were, what type of AAT do veterans and people with PTSD utilize? Is there a relationship between that PTSD and AAT? And then how does AAT impact occupational performance of these people? And then what other types of therapy do people utilize while engaging in AAT? So what we did to conduct this study was an 18-item mixed method survey. We used Google Forms, and it consisted of both
consisted of both open-ended and closed-ended questions. So questions about what types of AAT to use, age, demographics. And then also we had a fill-in-the-blank open-ended question such as, in what way do you feel AAT has affected your symptoms of PTSD? So we ended up getting 5 participants. They were actually all female. We did not get any veterans. And from an online anonymous source, and they ranged from 22 to 31 years old. And the animals they used were dogs and cats. We actually had 3 people report dogs and then 2 people report cats, which is funny because that's actually like the makeup of our group. We have 3 dogs and 2 cats between us 4, no relation. And then the context was 2 people reported in the home, outpatient clinic, 1 animal support, and 1 service animal. And then the time they engaged in animal assisted therapy was 6 months to 6 years. And then the reasons for seeking AAT was all 5 reported mental health, which was what we wanted. And then 1 person reported neurological, and they did not specify what neurological reason. And then we used SPSS and statistics to analyze the demographic analysis. And then our survey examined and compared participants' symptomology of PTSD before and after. So what we have in this graph is symptoms reported before AAT. So if you look at it, you can see that we have 5 out of 5 participants reported anxiety, fear of entering social situations, avoiding people or places. And then we have 4 out of 5 participants reported increased heart rate. And then 3 out of 5 participants reported loss of appetite, insomnia, paranoia, and those are all the hallmark symptoms of PTSD. So now we'll break down the themes a little more.
In our mixed methods design, we included open-ended questions in case the respondents didn't want to participate to a follow-up phone call. We asked them the following questions. What was a typical day like for you prior to receiving animal-assisted therapy? In what ways do you feel animal-assisted therapy has affected your symptoms of PTSD? And how are your mental health symptoms affecting your life role prior to receiving animal-assisted therapy? So what you see here are the 3 main themes that emerged from the respondents. The reduction in symptomology of PTSD includes anxiety, heart rate, blood pressure, mood, agitation, flashbacks, and suicidal ideation. An increase in societal roles. So our respondents identified that they were either a friend, a student, or employee. And then companionship and co-regulation. And co-regulation is the human and animal interaction that creates a supportive bond, allowing the human to maintain a regulated state. And then the next slide, you'll see here a breakdown of more quantitative and qualitative data. So for qualitative data, we asked participants to rank the change they experienced as a result of animal-assisted therapy on a scale of 1 to 5. 1 being decreased a lot, 2 being decreased a little, 3 being no change, and 4 being increased a little, and 5 being increased a lot. So what you see on the left column is the change they reported in physiological symptoms before and after AAT. What our results show is that all 5 participants reported an increased mood after receiving AAT. 4 out of 5 reported a reduction in physiological symptoms. And then 3 out of 5 reported decreased agitation after receiving AAT. In the right column, you'll see some statements made by participants, really highlighting the impact their animal has had on the reduction of their symptomology. 1 participant stated, "Animals have definitely comforted me during an episode and a flashback." Another participant stated, "I would not be alive today without him," meaning his dog. And then 3 participants reported a decrease in suicidal ideation, meaning they are no longer thinking about ending their life because they had participated in AAT. Deanne will talk about the next 2 themes.
The second theme is an increased participation in societal roles. Symptoms of PTSD can take a toll on one's mental health.
It can have debilitating effects on how one maintains, establishes, or participates in societal roles and relationships. Our studies showed that before engaging in animal-assisted therapy, all 5 participants reported both fear of entering social situations and avoiding people or places. One participant was a student, and she stated, "It was hard to keep up with schoolwork and everyday life, and as a result, her grades started to decline." Another participant reported, "I felt like I was alone and no one was listening." All the participants' relationships were affected in a negative way. They were scared to be alone, to be out in public, or hypervigilant. After animal-assisted therapy, all 5 participants reported reported increase in social participation, increase in participation in leisure or play activities. Our third and final theme is companionship and co-regulation. After receiving animal-assisted therapy, all 5 participants reported increased ability to control their emotions. Some emotions that had the most improvement were increased mood, motivation, and decreased agitation. One participant quoted this about the feelings towards animals: "They bring us back to reality and make us feel as though we are not alone. Animals provide no judgment, just love."
We asked about what types of therapies our participants use while engaging in animal-assisted therapy or in conjunction with animal-assisted therapy. And the co-treatments that were reported by our participants were talk therapy, pharmacological treatment, alternative medicine, and physical therapy, with talk therapy and alternative medicine being the most reported co-animal assisted therapy treatments. OT was not reported as a co-treatment by any of our participants, and this may be due to the lack of research into animal-assisted therapy and or also our small sample size. As we mentioned previously, our findings confirm that animals improve the occupational performance for people who participated in animal-assisted therapy. As OTs, we can recommend animal-assisted therapy be integrated as a complementary therapy into our clients' treatment plans. We found that animal-assisted therapy can increase a person's willingness to engage in therapy and can also improve a client's relationship with his or her therapist. This information is helpful for OTs since our clients are sometimes hesitant to participate in rehabilitative services. We can collaborate with agencies that provide animal-assisted therapy, and together we can provide occupation-based interventions in conjunction with the expertise of a trained animal therapist and service animal. We can even become trained animal therapists ourselves. The results in our study further support the psychosocial benefits of AAT, like reduction in symptoms of PTSD, increased participation in societal roles, and increased co-regulation. Further research needs to be conducted in order to understand how OTs can best use AAT while working with clients who have PTSD. We want to give a special shout out and thank you to the inspiration behind our research, our pets Cash, Chico, Butterbeer, Maciek, Abby, and Mercy. Also, thank you to the OT staff at Springfield College who guided us throughout our research process. Does anyone have any questions?
Are there any questions? I'm not seeing any posted here.
Thank you, Andrea.
I have a question. Oh, here's a question from Lori. How does one become trained to provide animal-assisted therapy?
There are different places that offer certification and dog training. As of right now, AOTA doesn't have like a national set of agreed rules or anything like that. So it's kind of just whatever independent place you can find. I know I worked with Heroes, Horses, and Hounds last semester for management, and she offers like a special training but that's like through her. So that's all I know of. Oh, and that brings me to my second question. Yeah, Heroes, Horse, and Hounds, they offer something.
Will any of you be using your animals in animal-assisted therapy?
I plan to.
Right. Oh, I would love to. I've seen people using dogs with little kids with brain injuries, and they respond really well to that. And it's the same thing of like facilitating range of motion by petting them and encouraging that bond. And of course, therapeutic horseback riding has been really, really beneficial.
If you were encouraging people to use AAT with OT, what would you want them to know?
I guess we would want them to know the different like resources that are out there for people to get animal assisted therapy. You could own your own service animal, or you could go to a facility like Heroes, Horses, and Hounds and receive therapy through there in conjunction with OT if you wanted to bring it up to your OT's attention.
Hello all, I'm Renee.
I'm Steph.
I'm Kelly. And I'm Kim.
And today we are going to present to you our project, What is This Wellness Thing? A study of wellness perceptions in older adults living in a continuing care retirement community. So the objectives of this research stemmed from a really unique connection that Springfield College has with the Loomis communities and their 5-year wellness initiative. For those of you who don't know, the Loomis Communities is a continuing care retirement community, and they were the first of its type in Massachusetts. And being the first, they're constantly trying to stay ahead of trends and stay up to date so that the older adults that they serve in their community are happy and enjoy living there. So in order to help them progress this 5-year initiative, we developed the following research questions. Our first research question was, what are the current perceptions of wellness of older adults living within the Loomis communities? Our second question, what are effective assessment tools for assessing wellness for older adults living in a continuing care retirement community? And our third question, do these assessment tools align with the Loomis community's definition of wellness and with residents' perception of wellness? In order to answer these questions, a mixed method approach was used through a Likert scale and open-ended survey questions to measure current knowledge of wellness of the participants living within the Loomis communities. Additionally, in the fall, we had a unique opportunity to conduct 8-week wellness groups with 2 of the campuses, and we were able to use the data collected during those studies to do a retrospective comparison of data to help better inform our results. The participants in our study were residents of the Loomis community's 3 campuses. These consist of Applewood, which is in Amherst, Loomis Village in South Hadley, the Loomis Lakeside at Reed's Landing, which is in Springfield. The numbers that you see next to those communities are the number of residents that were currently living in those communities at the time that our survey was sent out. We used a paper survey that was sent out to all of the Loomis communities via their internal mail systems. In order to analyze the data once our surveys were returned, quantitative survey results were run through SPSS to analyze descriptive statistics using frequencies and comparing means using one-way ANOVA and paired t-tests. Then thematic analysis was conducted on the open-ended responses from those surveys. And finally, we compared the data through both quantitative and qualitative means to better understand the perceptions of wellness within the Loomis communities.
So beginning with the qualitative data through triangulation and multiple levels of coding, we identified 3 themes to encompass all of the responses we received. The first theme was interpretation of wellness, which was defined as how each person read, understood, and interpreted the question or definition for each dimension affecting their opinion for their own personal wellness. Depending on individuals' experience, prior or current professions, and values, their overall understanding of each dimension varied, which then affected their level of satisfaction within that dimension. The second theme we identified was opportunities. This was an in vitro quote, which refers to a person's access to participation, experience, and involvement within each dimension of wellness. The residents identified numerous activities and programs that the Loomis community offers, allowing many opportunities for the residents to enhance their satisfaction and understanding of each dimension of wellness. And then our third theme was effects of aging, which refers to the cognitive and physical changes that are occurring in older adults' lives as they age and how these unavoidable changes enhance or hinder their performance within each dimension of wellness. One resident responded, "I am willing to accept others' limitations as I realize they are soon to be mine too." The awareness of these changes and the impact it has on their daily lives might have also impacted their satisfaction level.
For our quantitative data, we received 58 of the 485 surveys we handed out. So that gave us an 11.9% response rate. Through SPSS, we ran a one-way ANOVA to identify the effect of where participants lived on their individual rating of each of the 8 dimensions. So this analysis brought back no significant data. The spiritual dimension was very close to being statistically significant with P equaling 0.054. So that made us take a look deeper into this dimension. And this is when we realized how the numbers were so varied between the 3 communities. And having spent time at these facilities for our 8-week groups, we realized that Loomis Village scored the lowest mean score. Observations from that facility showed that they thought religion and spirituality were mutually exclusive. Loomis Village offers a Native American medicine wheel and other spiritual offerings. Loomis Lakeside scored the highest mean score, and observations were made that residents valued attending church services and Bible studies. The discrepancy in mean scores here is interesting and shows that understanding in each dimension is different. So in doing more data analysis, we used a retrospective look back for data we collected from our 8-week group through Adults 4. Through this class, we ran an 8-week group. Kelly and I were at Loomis Lakeside at Reed's Landing with 5 residents, and Renee and Kim were at Loomis Village with 6 residents. These groups were ran for 8 weeks, and each week focused on a different dimension. The residents were given a wellness wheel during the first week and again at the end of the 8th week. And using SPSS, we ran a paired t-test, and statistically significant results were found in occupational pre and post scores, as well as emotional pre and post scores. The results suggested that the groups for those 2 weeks were successful in improving the residents' understanding of wellness in that dimension. And what that means for Loomis is that they can try running workshops or groups to help the residents understand each of the dimensions.
So what does all of this information mean for Loomis and for occupational therapy? The study helped us to support the use of occupational therapy through the promotion of a holistic approach and client-centered care. Through the 8 dimensions of wellness, OTs can provide holistic care to older adults in continuing care retirement communities to help improve deficits around quality of life as well as other health concerns. Providing holistic approaches will allow the opportunity for improvement in all dimensions, such as socialization, occupations, and the environment. One focus of occupational therapy is to determine clients' needs and what is meaningful and purposeful to them in order to guide treatment planning. These approaches give OTs the opportunity to understand how older adults perceive wellness and what dimensions are important to them, which can assist in guiding treatment, as well as identifying priority treatment areas to address. We had originally planned and would have liked to complete interviews with the residents at Loomis to get more detailed responses and information about their thoughts on wellness, but we were unable to because of the current pandemic. Further research is warranted to gather the perspectives of a larger group of residents. This would include interviews that explore the different dimensions of wellness, the residents' perceived outlook on life, and programs offered at their community. Additionally, more research that explores assessment tools and wellness programs is warranted to better conclude which assessment tools are effective in measuring and helping older adults maintain their wellness.
We are hopeful that Springfield College is able to maintain this relationship with the Loomis communities and further their research and thus further their 5-year wellness initiative. So thank you for listening. If you have
Hi, hello everybody. I'm Allie, for those of you who don't know me, and myself, Megan, Nicole, and Kristen were a group with our advisor being Lori. And through our research that we did, we were able to do research that became really meaningful to us. It was a really great experience for us and also those who were able to participate, and we're very excited to share it with you. So, our research question and objectives. So our big research question that we came up with was, what is the effectiveness of a play and development educational program on perceived ability and comfort level of young parents living in shelters? So as we all came together as a group, we found that we all had a common interest in wanting to explore caregivers for our research. So we were fortunate enough, with the help of Lori, to partner with a local shelter in the Springfield area that houses expecting and current young mothers. So our main focus and purpose was to explore how these mothers in this population understood the different developmental milestones that we've all learned about, and the importance of play opportunities that are also age appropriate and follow these milestones. We also wanted to help them learn that anything can be made into a toy or a game. Household items and low technology resources can be used for play. And then researching literature and other studies that worked with similar ideas that we had, we came up with 4 key factors that needed to be considered when implementing our study. And these 4 factors listed are low income, parent education and training, developmental play, and the benefits of parent-child bonding through play. We were presented with this opportunity, and we were so excited that we might actually be able to make a difference in some people's quality of life, even if it was just helping one person.
We conducted a mixed methods research design where both qualitative and quantitative data were collected. We created a pre-post survey of 15 total questions, which analyzed the parents' thoughts about the educational sessions and their perception of their abilities, confidence, and comfort levels while playing with their children. As Ellie mentioned before, recruitment of participants included 8 young mothers who resided at a Western Mass shelter for young parents. However, only 2 participants met inclusion criteria, attended all 3 sessions, and were included in the study. The 2 participants, just to give you guys a background, were both females. They were 19 and 20 years old. Both participants were of white race and Hispanic Latino ethnicity. One of the participants reported having a high school education, and the other reported some college education. Participants' children ages range from 5 months to 2.9 years. So with the lovely assistance and supervision of our research advisor, Dr. Lori Vaughn, who's a pediatric OT, we created 3 60-minute sessions over a 3-week period. During the first week, the purpose of the session was really just to establish a relationship and increase the parents' comfort levels with researchers. They were then asked to write down their suggestions for the preceding educational sessions. For the second week, the group consisted of the young mothers and their children. We provided an educational handout with a table that listed the milestones from 0 to 3 months to age 5 on cognitive, physical, and social emotional development. We also modeled low-cost activities that parents could use to provide play opportunities for their children, such as water bottle bowling. Lastly, the third group consisted of moms only. So we integrated the feedback received from the participants on parental patience, and we provided them with a sensory preference checklist, followed by a series of stations with different activities focused on the 7 senses. This session covered a discussion on sensory modulation while emphasizing how sensory play can assist with development and parental patience.
For our summary of results, as Nicole said, we analyzed the responses of 2 participants out of the 8 potential participant mothers at this specific shelter. Overall, we found no statistically significant results between the pre-surveys and the post-surveys for the quantitative data. The responses to 6 of the questions that had some changes from the pre to post survey did not have enough statistically significant changes, as you can see from the first t-value on the slide. These 6 questions focused on available resources for these mothers and the parent-child bond that they were trying to dive into more. The responses to the remaining 4 questions had either little or no changes from the pre-survey to the post-survey. And these were the questions that focused more on parent confidence and their comfort levels with their children and play. However, we did find clinically significant changes between the surveys, especially when it came to our open-ended qualitative questions. The responses that changed from pre-survey to post-survey involved the parents promoting development, learning patience, and strengthening that parent-child bond. After analyzing the open-ended responses, 3 themes evolved from these questions, and they were learning through play, the parent carryover through new experiences, and how patience is key during play with these children. These findings explain that the educational play sessions had a positive impact on the participants and the children in this population, and that this population may benefit from further educational sessions. More research is needed at this time to determine if there were more targeted findings. Some limitations definitely include that it was a self-reported survey, the sample size, and the limited time during the sessions. Future research should explore other ways to record data, such as interviews, being able to ask those follow-up questions, a larger sample size, and either having more groups to interact with the moms and children or longer sessions to interact with the groups.
So for clinical implications, the findings from the study can be applied to the practice of occupational therapy when working with young mothers. So this can be done by providing play opportunities that aid in development, and then providing education for how that play opportunity is aiding in their children's development. Also, by working with mothers to establish a sense of confidence and patience. Going into this, we were not really expecting to cover patience, but that was something that one of the participants really wanted to get out of these groups, and we did include that, especially in our 3rd group about sensory integration. And this can also help with enhancing their parent-child bond. So maybe it's something where they're not feeling as confident and that's impacting their bond with their child, or perhaps they're not feeling as patient, or that they don't have the abilities they want. So really working with the mother to enhance that bond with their child. And then helping mothers receive services they need. 2 of the mothers disclosed that they had children who have diagnoses of autism spectrum disorder. And one mother was currently receiving EI services, OT services, and The other mother did not receive services. She also shared a story how she was trying to get headphones for her daughter and was unable to with her insurance company. So we did provide them some resources, and this is something that OT can do. Also providing low-cost play options that do not include technology. Technology is something that does not really facilitate development in children, and we also knew that these mothers did not have a lot of money to spend on play options, so we really wanted to use things that were accessible in their home, in the shelter. And then lastly, utilizing our therapeutic use of self and using sensory integration principles. So we had one group that really just, we spent time with them, getting to know the mothers, having them getting to know us. And we wanted to do this to really build that therapeutic relationship with them. And then that way we figured that moving forward, we would maybe get, they would be more receptive to us and what we were trying to, what education we were trying to provide them with. And then lastly, using those sensory integration principles. So really teaching these parents and letting them try out different things they can do for sensory. So squishy balls and weighted stuffed animals, all that fun stuff. And then showing them that everyone has different sensory needs. And just as they have their different sensory needs, so do their children. And then here are our references. And then we would like to take a moment and thank Dr. Lori Vaughn for all of her help and assistance and guidance through this process. So a round of applause.
Thanks, Lori.
Hello, everyone, and welcome to our research presentation. We are very excited to share with you our hard work we have completed while researching the relationship between movement paths and classroom behaviors. Throughout this research, as Kathy just mentioned, we were advised under Dr. Elizabeth McAnulty. My name is Casey Walsh.
I'm Meredith Teeter. I'm Rachel Santos.
And I'm Kayla Kohansky.
To begin, for those who are unsure of what a movement path is, it is a pathway as depicted on this slide here that integrates various senses within a brief period of time. Within our literature, it was found that multiple senses are activated with movement-based activity. It can reduce a wide range of problem behaviors. Typically, movement paths should only last for a few minutes. This particular movement path is designed to last for 1 to 2 minutes. Completing a movement path helps to engage children in physical activity during the school day at their teacher's discretion. Thanks to a willing OT within the Western Massachusetts Public School District, we had access to this movement path, and then we're connected to teachers to be able to work with their students and to carry out our research. As you can see, there was 2 objectives that were our platforms for our research questions. Our first question was, in a public elementary school classroom, how does a student's use of a movement path affect teachers' perceptions of problem behaviors that affect students' readiness for learning over the course of 2 weeks? And for our second research question, it was, in a public elementary school classroom, what are teachers' perceptions of using a movement path to help maintain problem behaviors within that classroom?
So for our methods, we use an ABC approach throughout our entire research process. The first week, which was week A, is where baseline data was collected. Behaviors of the students were observed by the teachers within the classroom, and no intervention was performed for all 5 days that week. Data was collected each day for all 3 weeks using a daily behavior form, which will be showed later within this slide. The second week, week B, data collection occurred all 5 days, while the intervention occurred 2 out of the 5 days. This is where us, the researchers, went to the schools to bring the students to perform the movement path. The third week was each of the teachers' individual choices if they wanted to continue with implementation of the intervention exactly how it occurred during week 2. So data collection all 5 days and intervention 2 out of 5 days. This was completely out of their own perception if they found the intervention to be effective for their students and for their overall classroom management. This chart shows our participants throughout the research. As Casey said, we were within the same school district, within the Western Mass area, and we were at 2 different schools. At each of the schools, we had 2 classrooms. So at one of the schools, it was 2 general education classrooms, and at the other school, it was 2 behavioral classrooms. Overall, throughout the 2 schools, we had 6 teachers and 12 students participating. And this is the daily behavior form that we created and the teachers filled out every day for each of the children. It lists 8 behaviors on the left, and the first 4 of them are physical behaviors, which are interrupted class, got out of their seat, got out of line, and disrupted others, while the last 4 behaviors are non-physical behaviors. They used inappropriate language, lost focus during class, they were non-compliant, and they didn't cooperate with their peers. So simply the teachers would just check off how often they performed each of these behaviors individually. And for the non-intervention days, we instructed the teachers to closely observe the students during the morning time for a few hours. And then during the intervention days, we instructed them to closely observe them a few hours after they completed the intervention.
In order to evaluate our data, we combined the 2 behavioral classrooms and then the 2 general education classrooms to create larger sample sizes. And then to analyze our data, we then found the modal number for each behavior for each child. So this chart shows all the behaviors and their p-values for the behavioral classroom, and it shows that we had 1 significant change in behavior, which was disrupting others, and has a p-value of 0.003. Although there was only 1 significant number, we noticed a general trend. There was 6 out of the 8 behaviors that decreased with the use of the movement pathway. And then in the general education classroom, there was no statistically significant numbers. However, we also, again, noticed a trend. But in this one, there was only 3 out of the 8 that decreased with the use of a movement pathway. So overall, we can conclude that the movement path had more of an impact of behavior in the behavioral classroom than in the general education classroom.
See if I could get you on like a FaceTime.
And then we also had a post-teacher survey. And this survey was to view the teacher's perception of the movement pathway, and questions included their likeliness of using the movement path in the future, their perception of the effectiveness, and the classroom management strategies. For the results, there are mixed findings from the 3 teachers that filled out the survey. However, all of the teachers chose to continue the intervention in the 3rd week.
So there are many implications that relate to OTs, as OTs serve as the bridge in this process within the school system. There are several different classroom management techniques. However, the use of a movement path is often overlooked. And sometimes teachers may not consider using the movement path prior to education and OT collaboration for several reasons. Some teachers may have never even heard about a movement path. Some may have seen it in the school, but have not received any proper training or just a simple run through on how to do it. And some teachers may think that they don't have enough time available or free throughout the day. So the goal of the movement path is for it to not be used as a punishment or even a reward system in the nature of regarding the problem behaviors. However, it should be used either as a small group of students at a time or during transition times, such as coming back from lunch or other class activities, or for students who eventually gain the skill to use it and request it as a self-regulation technique. It is the occupational therapist's role to advocate for the placement, the funding, the education, and then the proper utilization of the movement path. So occupational therapists should be advocating for the placement of a movement path, as not all schools have them. And they do this by advocating with the principals and just keeping an open discussion with the higher administration personnel. And OTs should also advise proper placement of the movement path, which would be there where there is moderate traffic in the hallways or other areas. It should be visible with clear instructions, and it should be easily accessible for all grade levels within the school. So OT and teacher collaboration is really key to ensure that proper and consistent use of the movement path is happening. So OTs can help teachers and other paraprofessionals to coordinate their daily schedule and to use the movement path on a frequent basis. OTs should also be tracking and collecting frequent data that studies the effectiveness throughout the school year, and then also just receiving that consistent feedback from the teachers who do choose to use it. And then just creating an open communication dialogue and that teacher buy-in to use the movement path on a frequently basis can only increase positive outcomes for both people, both teachers and students. And then, like some groups, our data was collected during the last 3 weeks that the schools were open, and our binders were collected on the last Friday that the teachers were in the schools before the COVID-19 pandemic. So as we work in school systems, there are many added challenges, especially during this hectic time. So we would just like to thank everyone who was involved in this process with their great amount of flexibility, such as teachers, parents, participants, and occupational therapists within the Western Mass Area School District, as well as Dr. Elizabeth McAnulty, our research advisor, and Christopher Hackala, an advisor on statistical analysis at Springfield.
Great. So we did our research project on caregiver perspectives on a successful transition for young adults with IDD. My name's Nicole.
My name's Tanner.
I'm Lauren.
I'm Andrew.
All right, so the study was intended to further research on the perspectives of parents and caregivers in order to identify various factors which they believe might influence a successful transition from adolescence to adulthood for their child with an intellectual and/or developmental disability. We felt that by developing a richer understanding of parents and caregivers' perspectives, it could yield valuable information for not only transition programs, but also for the professionals that are working with transition-aged youth and young adults. So this includes educators, occupational therapists, social workers, counselors, and job coaches, just to name a few, which really relates to the secondary purpose of our study, which was to use this information to help inform occupational therapy practice and to determine if the areas that influence transition identified by the parents and caregivers in our study were within the OT scope of practice. So essentially looking at these areas identified and determining if OTs can help increase independence and overall function in them.
So we conducted a mixed method study utilizing an online survey consisting of questions relating to demographic info, as well as one open-ended questions. The participants from the study were parents and or caregivers of young adults who were involved in pre, post, or current period of transition services. Also, we thought it was important to differentiate between the participants and the individuals who we often referred to throughout our research. The individuals were themselves the young adults receiving the transition services. Again, the participants were the parents or caregivers. Some inclusion criteria and exclusion criteria to be included in this study. The participants had to reside within the Northeast region of the US. And for exclusion, families of young adults with intellectual disability disorders older than 25 or younger than 12 were excluded. Participants were recruited by contacting various local organizations that provide services to young adults with intellectual disability disorders. For our recruitment and data collection, following IRB approval, a letter was sent out via email to parents and caregivers. This letter introduced our purpose in carrying out this research and provided a link to the survey via Google Forms. Upon opening the link, an informed consent form appeared, and then after selecting to agree to participate, the survey appeared. For our description of the instrumentation and design, the electronic survey consisted of questions about basic demographic and descriptive info, such as the age of the individual, gender, diagnosis, and type of transition program. And then the open-ended question was derived from a study by Henninger and Taylor, and as follows: thinking about this individual's strengths and difficulties, what would a successful transition to adulthood look like for him or her? As far as our data analysis goes, we used qualitative analysis to interpret and describe themes within the open-ended responses in order to develop an understanding of both the parents' and child's needs. And quantitative analysis was used to determine frequency of demographic data in order to gain an understanding of the sample and generalizability of the data.
So we had 49 parents and caregivers answer our survey, and 43 of those responses were found valuable for qualitative data analysis. Out of these responses, we found 11 significant themes. Employment opportunities was the top ranking theme, which included over 62% of responses. Responses to this theme were coded if the participant mentioned either part-time or full-time employment, and many of these participants noted that meaningful employment opportunities were an important part of a successful transition to adulthood. Other major themes included living apart from parents and caregivers, which ranged from independent living to living with a roommate or living in a group home with supports in place, as well as social and community engagement, continued services, life skills such as cooking, money management, and computer skills, and being in a safe environment such as a day program or permanent placement with trained staff. Less frequently occurring themes included leisure and recreation, physical and emotional health, and continued education, to which participants mentioned their child either taking college courses or participating in opportunities for intellectual growth. Overall, our results are consistent with IDEA's 3 pillars of transition services, which are employment, independent living, and further education.
So all of the themes that Nicole just mentioned strongly correlate to the occupations highlighted in the occupational therapy practice framework, and they're all fundamentally related to the values fostered within the profession of OT. Within this framework, occupational therapy is defined as the therapeutic use of everyday activities, aka occupations, with individuals or groups for the purpose of enhancing or enabling participation in rules, habits, and routines in home, school, workplace, community, and other settings. Therefore, we are well equipped as OTs to assist during this transition period to adulthood for individuals with IDD, as we can use our unique perspectives and skills to provide a holistic, client-centered approach to transition services. As our findings suggest, it is important that transition programs prepare individuals with IDD to participate in ADLs, IEDLs, education, work, social participation, community engagement, play and leisure activities, and independent living opportunities at the highest possible level of independence. As OTs, it is vital that we become more involved in the transition process and use our unique skill set to provide transition services that employ physical, social, cognitive supports and promote function within each of these areas. It is important that therapists who work closely with transition-age youth and young adults ensure that services meet the unique needs of each individual so that they're better able to achieve the conventional markers of success during the transition period to adulthood.